Not like, I feel like better actually. A little bit.
But so where you have pain is?
Not where my, like just other
Other
areas,
places,
yeah.
okay? Now, why is it important to do that?
You need to know what you need to do, like what you can do in this session, right?
Nope, one more. Oh, continue.
To know what to expect.
Yeah, he needs to know that it's normal. Because think about it. What's the whole goal of the evaluation? Right? They produce their pain, right? And not only do we produce the pain, we try to do it in every possible direction. And we do it repeatedly during driver testing, right? So, during the IEE, which I forgot to do yesterday, right? I should have told her, listen, it's normal to feel some soreness. The whole goal is to produce your pain, okay? And if you feel some pain, it should really go away after 2 days, right? It's more like old-fashioned soreness. I don't like try to provoke the pain a lot, just a little bit in and out. So that's why if I forget to say it, that's why at the beginning of the session I always say that. I'm like, hey, it's normal to feel pain. I was curious to see how much pain you were having. That kind of guides me on how much to push. Okay? All right. So then now I'm gonna ask her. So how's it going? Okay. Now it's very controversial. Like some people say you should ask about pain. Some people say you should ask about function. All right. If you ask about pain, what's the problem there? They're only gonna concentrate. Some patients, unless they have 0 out of 10 pain, they don't think they're doing better, right? They can have 10 out of 10 pain during the eval. They can have 1 out of 10 pain. They still think they're not getting better, right? That's how some people are, right? So this is why sometimes we ask people how you're doing. You can also then do a function. So when it's standing better, it's twisting better, stuff like that, right? So how are you doing, right?
Feel better.
Feel better.
Yeah.
So then it's very vague, right? It doesn't
Yeah.
help you because remember everything is based on what? The function activity, right? So so with you is prolonged standing, right?
Yeah.
So since we saw you, did you do any prolonged standing? No,
Not really,
right?
yeah.
Right, we saw last night, right? How about twisting? Does that still bothering you?
It feels better actually.
Feels better, right? But functionally, we don't know, right? Because you're just testing right in front of my face, right? Okay. So then, what's the other thing she said? Function. What's one big one? No, a big thing she does.
Twisting, right?
You guys have listen to your patients. It's the biggest thing. Sleep. She said she tosses turn all night. Huh? She said that. She said that, right?
Yeah.
She said that more with us, I think.
Yeah, I'm not sure. Now I'm not sure if she's with
Yeah.
you. Oh, okay. Yeah, she
I
went
said
do
it, but I
that.
said it quick.
Okay. So the thing is, whenever a person mentions sleep, you need to be all ears, right? Because why? If a patient has pain with sleeping, that means, 6 to 8 hours of them sleeping, they're causing micro damage. So it's very hard to fight 6 to 8 hours, 7 days a week, right? 50, 60 hours of micro trauma, right? Versus, an hour of physical therapy, right? Yep.
Is that a good goal that we could write?
Absolutely. It's actually one of the biggest goals insurance companies care about, ability to sleep. Okay?
How do you measure that?
Yeah, so how you measure sleep? And how many times they wake up in the night, how much pain they do have in the middle of the night, or how they wake up in the morning, pain versus stiffness, right? Or the biggest thing is that how long does it take them to recover from waking up? Some people say, no, it takes me like 2 hours moving around before I start feeling good, right? Because then that's all affecting other parts of your function, okay? So actually you're right, yesterday I should have delved more into sleeping. I know that the group did, right? But typically, how many times would you wake up in the night?
I think I woke up like 2 or 3 times last night.
No, but typically.
But typically,
Yeah.
like 4.
Alright, so she went down 50% maybe, 25%, right? And did you try the pillow positioning?
No, not really. The hotel doesn't have that many pillows.
We always ask the front desk for more pillows, by the way, okay?
We already did.
They did it, and we gave you?
But yeah, but it's not enough.
It's not enough, okay. Okay, so then definitely tonight try the pillow stuff, right?
Okay.
Okay, alright, so am I gonna do a full eval? Am I gonna do a column 1, column 2, column 3? No, because why? Usually treatments take less time, okay? So usually you go straight to column 2. Okay? Go straight to column 2, alright? And see what's going on. Oh, by the way, how is it tingling since the last time I saw you?
Good. I get that like sometimes, like not too much, but
Okay. Alright.
felt better.
So we're gonna so during a follow-up you do your column 2 and then your key column 1 stuff. Alright? What was her key column 1 stuff that was positive? That the H&I test, right? What else? The stork. Okay, because remember, are you doing a stork test, right? What are you doing? You're testing the spondylolisthesis. You want to see if that's getting better, right? And what's the other key thing that was positive in her case? Yeah, the slump test, right? So I just want to see how the slump test is doing. The H&I test is part of our functional test, right? So I'm going to say that a little bit, right? So, ready? Hands behind your back. Okay, you want your left leg, right?
Right leg.
Sorry, right down. Alright, right leg straight. Dorsiflex. How's that?
It's still there.
Still there, okay? Come on down, okay? Now, when you do the slump testing, right? How do you gauge if a person's getting better or not, right? It's not positive or negative, but it's positive with how much knee extension, okay? So, for example, right, when you do this, right? No. Dorsiflex first, then you took the load everywhere except for the knee, right? Okay? And then we see how much knee extension she has before pain comes in. So as soon as you feel pain, stop, okay?
Yeah.
Huh? Come down. Tell me when you have it again. Tell me
Okay. Look at there.
Okay? And that's pretty good, right? Because she has it, what? End range knee extension. But we load her here, she's dorsiflex, she's loading everywhere and only at the very, very last pain, okay? If you do slump testing and it's write down positive or negative, you have no idea what? Yeah, the progress you're making, so that's very good, alright? So, have you been doing your exercises?
I did like once last night.
Awful.
It was hard to.
Awful, okay. And then you always have to give a speech to patients about exercises, okay? Because exercises are the most important thing. It's the only thing that's going to maintain everything, right? So, what do? Do we give them a lecture? No, I don't know. I'm not sure how effective that is, right? But you just have to keep it real with them. So essentially, my goal is to get you moving, right? And then you see your stiffness here, stiffness there, right? As that gets better, you'll move better, right? So it's best use of our time that I can kind of see the bigger picture, keep moving things along, right? It's not ideal if I keep doing the same techniques over and over again. So in order to prolong what we do here and what we accomplish, is you can do those exercises, okay? I'm gonna do my best to keep the exercises down, right? Because PTs are horrible. We get like a million exercises, and then we get mad at patients for not doing millions of exercises, right? Right? So according to research, like no more than 5, right? So my goal is to give you around 5, no more than 5, right? So it's really I'm asking for like 10 minutes a day. See, when you put it that way, right? Framing it, it's like 10 minutes a day, right? If it gets too much, you gotta let me know, because we get carried away. I totally get it, okay? And also, they're very diagnostic. It's like to be giving medication. I gotta see which medication is helping you and which one's not. And sometimes, I don't say you, I'll say sometimes my other clients, if they don't do the exercises, I'm not sure which way to progress because it's hard for me to see the whole big picture. So, it's not very alright? And then usually cap it off depending on the patient, right? And it's hard because with your particular insurance company, we have like 20 visits a year, or we have 10 visits per year, so we gotta make the most of it, right? So they have to see the whole reason why. Okay. All right, so we did the slump test. That's pretty good. All right. Let's do the stork test. The right leg was up, right?
Yeah.
Right leg up. Okay. And backwards. Tell me when.
There.
Okay, so that's pretty good. She's getting further and further and further, right? Okay. So her motion was bend backwards and to the left, right?
Yeah.
All right, good. And backwards. Then to the left. Tell me when.
There.
Okay. So you see it's pretty much further, right? And then last time, what was it? The key driver was what?
Thorax.
The thorax, right? So I'm gonna correct it. Okay, now I actually can't correct it. From yesterday, I could do only partial correction, so now I can fully correct it, right? I'm doing, here's the left and right one, so now bilateral, right? Bilateral, right? Posterior rotation. Okay, ready? Bend back to the left. How's that? Okay?
Yeah.
And by the way, when you do the correction here, right? As the person moves, right? You have to maintain the posterior rotation and distraction. Okay? So ready? Go ahead, do it again. A lot of people, they don't maintain it and kind of do this. You okay?
Yep.
Okay. Right? And sometimes you're not getting a lift. So you notice I move with her. Ready? Go ahead. Right?
Yep.
Okay. So the ring stuff works, right? So that's still her main driver. Okay? So what do? Right? Right? We need to assess what's going on. Okay? She has a bilateral one. Okay? So how do we treat ring dysfunction as bilateral? There are two ways.
Would
If it's glued, right? So what do?
both posteriorly?
We could release the intercostals in between, or not necessarily the obliques, but just do a stack and breathe. Hold it, breathe, resist in my hand. All right? Yeah. So let's release the intercostals because we didn't talk too much about that. Okay. So lie on your side. Let me start treating her first, and then I'll answer questions. Just takes a while. Just face the class. So the intercostals, right? No, this is fortunately not the most comfortable thing to do. Okay. The intercostals are very confusing because there's no internal, external intercostals, right? So this way, and you go up and down too, right? And then also they had 3 different nerve supplies, so you have to release them like, through the front and back. Okay. So it's not the most comfortable thing. So essentially what you do, you go between the rings, you feel anything tight, you know, and what do? You just like hit the barrier and try to release it. Okay. And the best thing I try to do is don't look at the face because you're gonna feel so bad. It's not the most painful. Okay. All right. Questions. This is gonna take me a while. Yeah.
So what was the reason for manipulating her again yesterday?
Oh yeah. Why did I manipulate her yesterday? Because
You couldn't correct.
I couldn't correct her.
So when you tried to posteriorly rotate her, she didn't have much movement?
Yeah. When you try and posteriorly rotate and push back in, right?
Okay.
Right. When I do that, I could move only a little bit, not all the way. So then it makes me think, what, joint, right? So then when I assess the joint, you know, my side bend rhythms, she can move both left and right, all right? So that means anterior fixation. If it's just one side, then I'm thinking, what, no, ERS, FRS, whatever, right? Yes?
Following up on the next question, when you were doing the driver assessment versus the functional breakout,
Yeah.
what was the feeling like between the two where you knew you couldn't correct versus today?
Oh, because when I corrected yesterday, even during my examination, I said, okay, this is very hard for me to correct.
Looks like you were struggling.
Yeah.
Okay.
Okay, well, if it's hard to correct, you're thinking different caps. Yeah.
Are you with Christina gonna have to do both sides bilateral?
Yes.
Intercostals?
And when you're doing intercostal, you usually have to do both sides.
was
I
just
start with this
wondering,
side here because I thought this was more hypertonic. Okay.
So right now, are you, so like, you're basically finding like the little nodules and just kind of like rubbing them out?
Mm-hmm. Search and destroy. That's what we're doing. Alright.
You're
Yeah.
like pinch, I can't tell, like you're like kind of like, yeah, like pinch, you're just doing,
So imagine this is the 2 ribs.
yeah.
My fingers are going between, right? And you're kind of gliding until I feel what? Friction. A
And
speed
you're
bump.
like using your
Yeah.
side of your knuckles.
Yeah. Well, it doesn't matter which side you use, right? The thing is the principle, right? Is you doing, it's called you could call it the finger glide test.
Mhm.
Until you feel a speed bump. Oh, that's my speed bump. Once you hit the speed bump, what do? So you try to see which direction is the most stiffest, and then you attack that one. Yeah.
So now, today, after you manipulated yesterday, you found a glued ring, or was it glued yesterday also?
No, it was glued yesterday.
Oh, it was glued,
Yeah.
okay.
Okay.
So the manip did help.
You did help. I don't have to now manipulate again.
I was thinking about this last night. What's the difference between the manip we did that we learned yesterday and like the high volt, the pistol grip? Like in terms of like.
That was the same technique.
That, oh, they are. They're
Yeah.
the same thing.
Yeah. What I do differently?
That's what I was wondering. I like was
No, the
trying
same
to
thing.
think. Okay, well then
Yeah.
I know what's going on. So that's.
So that's over. Yes.
As far as blue green versus
What's that?
the blue green versus the stack and breathe,
Yeah.
which one would you do first?
No. You mean how do I treat glue rings?
No, I mean like intercostal or stack
Oh,
and
that's
breathe.
totally just your preference.
Okay.
Like, yeah, you can definitely do stack and breathe. I just find that it goes away so quickly, right? Because if those intercostals are glued, I mean, are hypertonic, I like to release them. Okay. Yep.
You can do release with awareness here too.
Yeah, release with awareness. So yeah, it's a good question. So like for example, I find a spot right here, okay? So I can tell it breathe into me. And then when you relax, let my finger just sink in, sink in, sink in, sink in. Okay? Only reason why I don't do it as much is because there's so many spots on the intercostals. If I did that, I'd be here like all day. Okay, relax, relax. I would do it for the really bad ones that won't let go. Because remember I said you have to do like the anterior, middle, and posterior part. Yes.
The vertebra that was anteriorly fixed.
Yeah.
Is that at the level of the ribs that you
Yes.
corrected?
Yeah, remember you gotta touch the ring and follow it back.
And you could feel that it was like forward?
No, you don't feel it's forward. If you can't have been left or right, then you know it's forward.
Okay.
Okay? It's hard to feel if it's in the forward position. Okay. Let's stand up. Okay? Alright, so remember, what we're looking for progress, right? Not 100%. Resolving the pain, right? And the key thing is when I do this, I am not supporting her. I'm what? I'm trying to feel when it starts what? Translating. Okay? Yeah? This is the most important thing because you want to be able to what? Kind of predict what's going on and give the right cues. Right? So this is equivalent. Can you feel when the femoral head is gliding? Do you feel when the human head is gliding? So then you give the cue to stop it. Right? Alright, so ready? Go ahead. How are we doing?
Good.
Keep going.
Move everything go on.
But pain?
Yeah.
Okay. So at the very end when she has pain, right here. So at the very end, that's when she starts translating. So what am I gonna do? I could try to release it more until it's totally okay. Or I could give her what? Cues to try to stop and translate out. So what's the cue we used yesterday? Scroll tall at the level of the rings, right? So when I do this, right? I'm not lifting her up, right? It's just giving what? Cues to what? To open up, right? Ready? Open up here. Right? Keep opening and go backwards. Keep going. Good. Keep opening, especially the right side. The right side wants to come undone. How are we doing? Pain?
Okay. Yeah, right there.
Right, come back, and I take it right before the point of pain. Grow both sides, and then go. Pain.
Yeah.
Right? So if with all the corrections still have pain, that means I still have to let them go. The technique. Right? Alright, so which hypertonic muscle? Release this one over here, got it. Line side, face the glass, left side. Okay, your goal is to get straight to motor learning, alright? Your goal is to get them to move. Okay. Oh my god. Oh my. This is like not friend here. Alright, so once I've done that, right? And I see this motion gets better, what else should I be assessing for afterwards, right? Or working on? Yeah, because we haven't done anything for the pathomechanical, right? So we need to what? Do what? All the multifidus training, because the multifidus is on the left side, was it the right side, do you remember?
It was the right side.
Was the right side? Right.
But it's
T
right
and
TA.
and left multivida, I believe, right?
Mm-hmm.
Alright, so she has that diagonal pattern, right? Which is commonly associated with poor twisting control, right? Because you need the opposites. Okay. There you go. This is usually how I get paid back to students. Remember that time you were late to class at one time at 25 seconds? Yeah, there you go. Keep my head though. I'll say out loud. Okay. So. Alright, so it's moving much better. The intercostals, okay? If it's not better, right? Alright? That means what? It could still be another driver somewhere else, right? Right? So let's see, right? Go back. Then back. Right there.
like really at the end.
Okay, so the very end part, right? So, and I don't feel a lot of translation over here, so there must be something else. Okay, so what were the other drivers that was helpful, but that's helpful as the rings? We had the SI, and when I did the lumbar pivot stuff, right? So when I did, oh no, I think it's helped if I recall, right?
No, I think this one didn't help.
Didn't help?
Yeah,
That one didn't help.
I think it was the
Pelvis that helped.
I thought it was lumbar.
Oh, you guys, so you guys are right. Okay.
It was IS.
It was IS. Alright, go ahead. Then back to the left. How's that?
Yeah.
Yeah? Okay. So what I'm doing is I'm doing this. Alright? Doing this. So her left side's anterior. So I'm pushing this back, okay? So I gotta see which one's what? Culprit? So bend forward. Right, yeah, left side goes up. Alright? So that means the left side's what? Anterior rotated. Okay. How can I fix that? Okay. So walk me through it. Go ahead. Lying side line.
Right side.
Okay. Want me to do this technique?
Isn't it the other side?
Huh?
What did we say?
Remember, her left pelvis was anteriorly, so I gotta move it posteriorly. Alright, so flexion like this.
No, that's her left.
Yeah?
Yeah. An extension of
Yeah.
lumbar.
One hand on her.
Okay, so we're all over the place here, right? Right? So first things first, we all forgot to do is what?
Leg length.
Check for leg length. There you go, good. Because we need to know what? Okay, yeah, we just need to know, like, is the treatment working? Okay? Yes, Brandon.
Let's say you did that correction at the pelvis, and the patient doesn't have a leg length discrepancy.
Yeah, like in the case right here, right?
Yeah.
Right? Because in her case here, her left leg is actually shorter, right? And those anteriorly rotated on this side over here, okay? What's that?
Do we have a set up a check? Or if it's
Yeah, when set up, please. Sit. Oh, and you don't change. Your partners found the same thing? You don't change?
Yeah. Who found it? I say? I think Sammy did.
Yeah, you didn't change?
Yeah.
Okay. Okay. So we have a structural one here, okay? So if this leg is shorter, right? The body will try to become taller on the shorter side. Does it make sense?
Mm-hmm.
And how can you make a shorter leg taller? Anterior rotate and arch, high arch. Make sense?
Mm-hmm.
Make sense? Make sense? So what'll be interesting is to see how much of this leg discrepancy is affecting her what? This motion here, right? So let's say the left leg is the shorter one. I'm gonna repeat it again and have her take her shoe off here and make this left leg longer.
You're gonna do the arch.
I might
like
take this
the-
one off.
No. You see this leg is shorter, right?
Oh.
This is your heel lift. You see? You see what I'm trying to do here?
Mm-hmm.
Okay.
Oh, because right now if you did anything to the pelvis, it's not gonna make,
Yeah,
it could make it worse.
it could make it worse, right? But I'm just curious to see how much the leg length is, right? So everybody understand why I'm doing this?
Mhm.
Okay. Ready? So bend back. So. How are we doing?
Like right there.
So still a pain at the very end part, right? So I'm not sure how much the leg length is a player, right? But then also if I did this, right, back.
Okay, right there.
Oh, still there, pain still there, right?
Yeah.
Okay. Then we stop, alright? Your whole goal as a therapist is to not force the issue. I found leg length, I think it must be the leg length, and then do what? Treat the leg length, you should get a shoe lift. No, you have to what? Test it out, okay? Remember the first day of class, I taught you guys, I said, your goal is to be an overall therapist, right? Don't be a person who specializes on leg length and think everything's a leg length discrepancy. Right? So I'm gonna have to look for something else, right? Yep.
Even if it wasn't like an upslip, like, it would correct itself when you sit up, right? If it was an upslip or
Oh, it's a good point. So if you have an up slip, right, it's not gonna change, right? When you do the whole sitting up and down stuff, right?
Okay.
So then, how do we clear off an up slip?
Check her ASI.
Extraction.
No. How do we know she has one, right? So,
We put her into anterior posterior rotation if the PSIS doesn't move.
well, we just check the PS and the ASIS height, right? Right. What's the other way we did?
Start test flexion.
No, and we do this test, right? If you can't flex or extend, that means you have what? An up slip. Okay. So I'm gonna do that one first, right? I'm just curious, okay? Okay, ready? Left knee up. Sorry. Okay. Take it back towards me. Accept weight. All right. Go forward again. And back towards me. All right. And I like to go back and forth. I like to appreciate the up down. All right. So go ahead. Up again. Up. Back down towards me. Accept weight. Good. Up towards you. Back down towards me. All right. So she can move. So I don't think it's up slip. Yep. By the way, the checking for the heights, that's the right way. But I told you guys the reliability of that is like so horrible, right? That sometimes I don't trust my own eyes. Movement is easier to see. It's moving up and down, up and down. Yeah. Yep.
Do you think if you gave her healer, the transabs and multifidus problem will go away?
Well, then you could palpate, right? Like, all you guys are asking great questions, so you just have to test it, right? Right? So if you think it's up slip, test the up slip, right? If you think it's gonna help with the multifidus, test the multifidus before and after, right? So I didn't teach you guys this, but the standing multifidus test is you put your hand like this, push up to my hand, and I'll palpate the opposite multifidus, right? Just like we do with the legs, right? Opposite multifidus, right? And then I'll test it with the heel lift and without the heel lift. Alright, if I'm thinking that's the culprit. Yep. You take your shoe off.
I kind of have, do you think the leg length discrepancy is maybe like a precursor for her ACL tear?
Yeah, maybe. Yeah. All right. Because anything that causes asymmetries, the body hates asymmetries, right? Because then the body has to work differently on both sides, and then it can result always weird different things. All right. But this patient, we still haven't found the driver, right? Oh, by the way, and the biggest thing with drivers, they change from visit to visit, right? When you treat one of them, right, it reveals the next layer. Huh?
Everyone laughed.
Okay. So, what should we do now? We have to keep finding more drivers. Come back.
Coming.
When I treat the pelvis, right, it didn't get that much, right? All right. So let me see. Treat the S.
Put him on a leash.
Could it be cervical, doctor?
It can be cervical. Bend back. Bend to the left. How's that?
That feels good, actually.
Any pain?
Release the tear.
Now.
No. Oh, can you do it again? My hand's left. Okay.
Not that bad, actually.
Okay, so when I did left SI correction, I had to hold on for dear life, right? When she gets to the very, very, very end, she's pushing my thumb out like crazy. Make sense? All right? So if I know that it's consoliding on this side here, right? Then I'm gonna do all my stress tests real quick, right? So right knee up, right? It pops out, confirms my suspicion that it's unstable, right? Yeah? Then I need to figure out why is it unstable, right? Then I'm gonna palpate who? Left side, right side? Left side. And that's not bad. Now, who else gonna palpate?
Erector spinae.
Alright. And that's on fire here. Okay. What else am I going to do?
Check piriformis.
How am I going to do that?
Have her internally rotate her leg. Heel
So
lift.
can you heel up here? Okay. And I'm going to ask you to turn inward and then outward. Got it?
Yep.
Hold it there. Can you do it for me? Keep going in and out, in and out. No change. Okay. And then what's next?
Psoas, step forward. And
Step forward,
lunge.
which leg?
Left.
Yeah, step forward, left leg. Keep your pelvis squared and translate forward. No, don't move the foot though, kiddo. What is that? I didn't see that one before. Okay, I'm back. Do it again. And that makes it worse. Okay, come back. Alright, so we have what? Erector spinae and psoas. Yeah? Yeah? Those are the two that I'm going to have to what?
Release.
Release, okay? So lie down on your back. Okay?
You poor thing.
Alright, one second. Let me finish with all training your thoughts first, right? So the whole class is following me, alright? So then, okay, I know about who's unstable again?
SI.
No, which side? Left side, right side?
Left.
Left, right? So I know which muscles, right? But then I still need to figure other stuff out. Remember, when things are unstable, we need to do what? You're gonna make them stable, yeah, right? But we know which muscles, is it right? Right.
So release the
So we'll do
barriers.
actually straight leg raise, right? Remember the whole flow, right?
Yeah.
So lift up your leg here. Come on down. Go a little bit higher. Okay. Come on down. You see she's shaking like crazy over here. Go ahead. Okay. Come on down. And then, is it easier or harder when I do this? Go ahead.
Same.
Same. Okay. How about when I do this? PSIS. Go ahead.
Better.
Better. Okay. So now I also know I have to what? I have to work on the multifidus. Okay. Remember, when I release the muscles, it just tells me which muscles might be pulling her there, but it doesn't tell me which muscle is going to keep it there. So you understand why we had to do both?
Yes.
Right? What's causing it? What's going to keep it there? Okay. And then I still have to do my SI mobility test. Why do I do this? Right?
S1 is 2 is 3.
I gotta see how loose is it, right? So it moves. That when I do S1, it moves very well. Okay. Once again, right? When I did S1, it moves pretty well. So does that telling me that SI is stuck in that posteriorly rotated state, or is moving in and out?
Moving in and out.
It's moving in and out. Do you see that key reason why we do the S1 testing? Because when I do S1, if it does not move, that means you have malposition rotated sacrum, right? If I could move it, that means yes, it's rotated, but it's unstable. It moves in and out, moves in and out. You see the difference? All right. Remember, because if it moves in and out, it means unstable. All right. That means I really need to do what? Give her an SI belt, or really work on that retraining to keep it stable. Yeah. If it's malposition, I need to really release things to get it moving again. Okay. So, hold up. I know you guys have a ton of questions, but this is the most important concept right here, because we just found those tight muscles, right? Right? I'm scared of releasing muscles now without giving her what? I might take away some of her stabilities, right? Yeah?
Yes.
Just don't go releasing muscles because it's tight, okay? So, her multifidus, right, it seems like it needs help. Remember yesterday, that multifidus wasn't firing at all. Alright, so I'm kind of nervous of start releasing stuff, and psoas releases and stuff like that, right? Because what does the psoas do? It's a stabilizer of the lumbar spine. It gets tight to stabilize. Right? So, that being said, I'm going to jump into multifidus training. Please step in. Okay. And then, okay, pull your stomach in. Relax, okay. Push. Relax. Push. And just doing opposite leg to see you get multifidus firing. Good. Push the other leg. Push it back. Push it back. Yeah, so it's the left side. Okay. Okay, head this way. Okay. And then I'm gonna just. So I can't get it to fire. So what do I have to do?
Purple cube.
So I'm gonna get a different cue first, okay? So imagine there's a string from here to here, and you're pulling these 2 points together like this, okay? So some people are usually confused. What do? You move them there, hold it there, hold it there, hold it there, hold it there. I'm gonna let go. You hold it, good. And I get some multifidus fire. Good, relax, okay? Do it again. Good. Again. Now this lower ones you have a hard time with. So ready? From here to here, pull, 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 pull. Good. Hold it, hold it, hold it, hold it, hold it, hold it, hold it. Relax. Okay. Keep doing. You need a whole bunch of repetitions. Now I want to answer questions, right? By the way, so sometimes I want to answer questions because it confuses the whole class. Because I'm trying to take you guys to a flow. And when I answer questions between it, then I lose half the class, right? So essentially, what happened, right? Her rings was no longer helping. So I told myself, must be another driver. The only thing that helped was the left sacrum correction. And then I do all my stability tests on the left sacrum, right? And then confirm, when I did this, yep, she's unstable. Okay, which muscles? And I found those muscles, right? Okay. Then I put her in supine, alright? And I did my S1 testing. So, whoa, this moves too much. This is an unstable SI. I'm not sure I want to really release things right now. So I need to strengthen it. But which muscles? And I do my active straight leg raise test. And told me what's going on with the multifidus. And when I evaluate the multifidus, it's not firing at all. Alright? And this is what I'm doing. Alright? Yeah, Nick?
My question is during the sword test.
Yep.
Why didn't you have her lift the left knee up and test to see if the right, or left knee up above 90, test to see if the right sacral base counter-nutated to see
Oh yeah, you're right.
stability and
I didn't do check counter-nutation on the other side to see if she's stuck there. That's another way I could have done that.
okay.
Usually I rely on the S1 testing.
Oh, okay.
But yeah, you're right. Yeah. Okay, keep on. Yep. I'll
When you decide if the patient needs an SI belt, like if they, it's like an instability, you just give them on Vicodin, and there is, you see if their intervention is helping.
Yeah, SI belts, you do it more if it's not working. Like if you do stability training is not working. Or two, the person is in so much pain, they just want some type of relief. Now, I'll talk about SI belts, right? Relax. But usually, active straight leg raise has to be the key. Keep on. Why are you stabbing so much for? Relax. Yep.
Are you also going to strengthen her right TA afterwards?
I can, but the thing is, during the active straight leg raise, it didn't help that much.
Okay.
Alright? So, you understand, patients will have tons of positives, right? Now, you guys did MMT. Everybody has weak glutes, everybody has weak hip abduction, Are we going to shrink everybody's glute max to everybody's glute needs, Is it messing with the functional task? That's right. Because you're right, I could work transverse abdominals, but then I need to do multifidus. Oh, that's right, I do the ring stuff, or I have to do the movement training, I do the hot pack modalities, I do my patient education, You have to be what? A sniper, right? Not shotgun approach. Like, let's see which one of these things will work, right? Okay, yes.
To go on Sandra's point,
Yep, go ahead.
wouldn't you, don't deep muscles co-contract, so wouldn't you possibly get a little transabs if you were like working on the multifidus?
Yeah, but I could directly get the multifidus. That's when I need more than transap, right?
Yeah.
The transap didn't help the task.
Oh.
Yep.
When you're gonna go all the way back into the side, that's when you entertain. So my question is,
Antiplatelet.
why aren't we checking the muscles in that position to see which one is the primary goal?
Oh yes, that's a good question. Normally I do that, but it's too complicated. Essentially, I would have done PSIS squeeze back when I would have done ASIS, not standing.
Okay.
The whole class will not like me. I take it another level. Okay. And I'm not sure you realize, now I've taught her how to do contract the muscle using an anterior pelvic tilt. Okay? Remember, anterior pelvic tilt gets the multifidus fire. Okay? Why do I teach this? Because in standing, right? In standing, it's much easier to teach a slight anterior pelvic tilt than approximate these two things. Right? It's just like they always lift the leg up. Right? Okay. So now the muscle's firing nicely. Stand up. Okay, so I want to do a baseline without any cueing. Bend back to left. Something went.
Not really. Yeah, now.
Okay, at the very end, okay? So now I'm going to tell her I want to do that anterior pelvic tilt. Okay, keep holding that anterior pelvic tilt, right? Relax. Do it again. Hold it more. I'm doing this until I get a nice contraction multifidus. Okay, keep holding that, bend backwards to left. Keep holding it, keep holding it. Keep holding, huh?
It hurts now.
Oh, now it's hurt, right? Because she's overlocking, okay? Because remember the whole Bernstein, some people will what? Overbrace, right? So do it again with what? Like half the force, okay?
Okay.
Right? Relax. Slight anterior tilt, good. Good, back to left. Good, back to left. Keep holding it, keep doing it, keep doing it. Keep going. Good. And come back off of it. Good. Keep going. So I'm working that end range, right? Boom. Boom. Okay? So you see, now she's going to the danger zone, protected, because the multifid is firing. Relax. Okay? So you see how we got there, right? This is why you have to be quick with your driver assessments, because you do it every visit. Okay? Because maybe that ring was over guarding for something else to happen, and when you release that, then you see the true cause, or vice versa, or whatever. But then everything's screaming at SI, right? I didn't want to start releasing everything, so that SI is too unstable. So I retrained it, and I taught it how to work in upright. Right? So I taught it how to do it upright. If you notice, I gave a lot of concurrent feedback, which is awful to do in motor learning, right? So that's why I stopped, right, with rubber cueing. And then I would progress it to go faster, more ranges, right? I love motor learning, okay? So actually, I should do that, just do the whole thing. Because that's what we're doing today, the whole movement control, right? So ready? Slight anti-pivot tilt. Okay? Hold it, go ahead, back to left. Okay? Keep going, okay? So motor learning says what, right? How do you progress it? Maybe go faster, maybe, right? Maybe we require more coordination cerebellum. Keep going, good. No pain, right?
A little bit, not really.
No, I don't want no pain, right?
I know, like, on the, opposite side.
So if you get the pain, which you should do, right? You have to reset. Slight anti-pelvic tilt again. Keep doing that, grow tall, and then go, okay? When you grow tall, that's a great cue for the multifid to fire, okay? You okay?
Yeah.
All right, see, no pain, good. Keep going, go a little faster. And then we do a dual cognitive. Hey, what'd you have for dinner last night?
Chinese food.
Chinese food? Where'd you go?
The one up the block.
Is it good?
What's it called? Yeah.
Was it good?
Yeah, it was good.
Was it really #1 kitchen?
Staten Island's better.
What'd you get? Chicken broccoli?
No, I got boneless spare.
Huh?
Boneless spare ribs.
Go a little bigger? Really? But why are you getting tough with the bones? You better get without the bones. It's so annoying.
I said boneless.
Oh, you said boneless. Oh, okay, good. Because the whole bone thing is like you're fighting against a little big bone there just for a little piece of meat, right? Same reason I don't get crab shells. You do so much work, right? Okay, and relax. All right. So you see what I did there, right? Motor learning. We went bigger range, went faster, did dual cognitive, okay? And my hand here is constantly just assessing, make sure the multifid is firing. All right. Yeah. All right. So your homework is to do that.
Okay.
Okay, you're gonna do it, right?
Yes, I'm gonna do it.
If not, you fail the class. Okay, that's good. Okay. Okay. Thank you, Christina. All right, questions. Birdie.
So she got farther before.
Hmm?
Why were we pushing her farther with that?
No, we can. All right. Remember the goal is to do bigger range of motion, right? So I will eventually get her to the
So
last.
small, then getting her.
Yeah, it's very hard to get everything on one shot type of thing. Because the thing is, I used to be like that. I must get full range of motion, right? But the thing is, it's better that they have some muscles behind it, all right? Is it better to get full range of motion with no motor control? Or is it better to get a lot of the motion with motor control, right? Because I used to be like that too. I used to be a hardcore manual therapist. I'm looking for everything. Look at you, you're moving great. And then they come back and they still be blah, all right? All right, no problem. I'll release it and come back. Okay, maybe we need some more stretching in HAP, right? No, the only things that keep things there is just strengthening, right? There are some lower back approaches where there's no manual therapy at all. It's all lower back exercises, and they get excellent results, right? I just think it's faster to use manual therapy to enhance it, right? So, I'm a fellow of the American Academy of Orthopedic Manual Physical Therapists. It's the highest thing you get as manual therapist, right? I love manual therapy, but you have to do the exercises to keep it there, right? It's the only thing that's going to get it's the stick. And the thing is that you don't want patients to be too passive. They think you're going to fix them, right? So no, you got to do exercise. Look how much better we get when you do activations, right? So the goal is not manual therapy. I try to be less manual therapy oriented, actually, and the patients don't like it. All right, yep.
Since Christina was only having pain with bending back and to the left, is it inappropriate to add variability for her, like maybe back and to the right, or just straight back, or?
Yeah, so remember, variability training is key. Why is variability important? Bless you. No. Remember, remember, if you keep doing this, right, and she's like controlling anti-poly tilt, right, her brain's gonna check out. Alright? I could do this and talk to you guys, no problem, right? Alright? Because the brain is like, when I go 25 degrees this way, do that, right? But if I have to move back this way, then this way, then this way, then this way, you know, playing around with it, the brain has to what? Turn on and learn. When I do this, okay, when I do this, I should turn the muscle at 50%. But over here, maybe I turn it at 25%. So the brain's constantly what? Thinking, and that's your whole goal. And also functionally, you're training them for real life. You know, the goal is not to be treated like this, right? The goal is basically to do whatever you want. Yeah. Yep. We'll spread the wealth there. Yes, Maine.
So she was moving well when you tested S1 on her,
Yeah.
her S. So were S2 and S3 not moving as well, or were they all moving a lot, and that's why you didn't want to do it?
What S1 was moving a whole lot. S2, S3, I think it was a K. Anything big, right? Like, let's test it really quick. You go boom, 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 boom. I know it took me an hour to explain the test yesterday, right? But it's really da-da-da-da, right? It wasn't nothing significant.
So if you feel like movement like that and the rest are normal, don't release the muscles. Focus on stability and motor training for the stability.
But when I say don't release the muscles, right? It depends how much time you have, right? If you have time, I release the muscles at the end of the retraining. Alright? Since I showed you guys releases yesterday, I thought it would be better to show you the motor control part. Alright? But if I have time, I'll release that. If S2, S3 is stiff, I'll release that, you know. Okay? Because you know, you have to release the S2, S3 because that could cause S1 to move too much, right? Okay. Okay. Oh, yes, another question.
So would you kind of tie it all together and say that because her SI moved a little bit too much, that's why all her lumbar, pretty much all her lumbar vertebrae were moving too much in the, because you think yesterday you were talking about.
Yeah, you can compensate, yeah, right? If you're stuck in left rotation, alright, maybe they're rotating more to the right to compensate. Okay? Like, these type of things, you gotta think about it all theoretically. It's just way too hard. Right? But theoretically, you can say, yes, you're rotating to the left and everybody's rotating to the right to compensate. Right? And the lumbar spine's horrible compensator rotation because it only has like 2 degrees of rotation. So anything more than that, whoa, look who it is. The Dr. Grau. They forget everything we talked about motor learning, by the way. Alright? You did motor learning, lower back. Say, hey, that's a different semester, who cares? Alright? Alright? How's the pig's feet? Not his dinner, by the way. Right? He's a vegetarian. He doesn't eat feet. Okay. I know, he's so big and buff being a vegetarian. Yeah, alright. Alright. So, okay. So the thing is, you guys, I taught you guys everything, right? But this part we're doing right now, putting it all together, no, that's just the hard part, okay? And I feel like we need more of that, and also, you know, help in preparation of the practical, right? So the goal for today is to do more of the same, okay? But I do have to finish up a couple more parts, right? So let's finish off the alignment stuff, okay? So